can I start by introducing myself? I'm the independent chair for this session, and my name's Nick Pennell, and I'm chair of Healthwatch Plymouth. And for those of you who know about Healthwatch, we are the consumer champions for health and social care, and we operate in an independent and we hope objective way. One of our key objectives and key intentions is to do our best to ensure that whenever there's changes or developments in health or social care, there's adequate and appropriate public engagement. So we're very pleased to be introducing this session, which of course is all about public and stakeholder engagement. I'd like to start just by going through a few formalities, the usual formalities, and I'll start with the toilets. If anybody needs the loos, they're just out through the doors where you came in front of you on the right. There isn't a fire alarm plan for tonight. If the alarms go off, it's out back through the main entrance into the car park area. For those people that have access difficulties, you can go straight out the doors there into the courtyard. I'm sure members of the team will help. And I think there are some refreshments still left on the table at the back if anybody would like a tea or coffee. I think one other point I'd like to make is that the proceedings this evening are being recorded, and they're being recorded in two ways. One is there's an audio recording that the CCG are taking, and the reason for that is that all points of view and everything that's said can be taken into account and considered at a later date so that nothing is lost. And Healthwatch are very keen to ensure that none of the valuable points that are raised are lost. So that recording is going to be made, and hence, as if people want to speak, I'll tend to wander around with the microphone and enable people to speak into the microphone, so we get a good recording. We've also got local media who are recording the event. I think it's going to be live on the internet. It's recorded for the internet. My apologies. Joe's overseeing that, and if anybody doesn't want to appear on that, speak to Joe and sit on that side, and you will be invisible as far as that's concerned. At this stage I was going to introduce the panel members, but I won't, because I'll let them introduce themselves. They're far better at doing that than I am. What I will say is the agendas for today are on the tables. You'll see the format fairly clearly in front of you. And we'll be moving on very, very quickly to the presentations that the panel members will do. Then we've got about half-hour plan for question and answer sessions. It's an opportunity to put any questions, make any points to the panel that will be recorded by the CCG. I've got a query. It's the inside of the large... Everybody got that on the large double size thing? It's the first page inside. We also have facilitators on most of the tables, and the facilitators will be making notes, recording those, but please, if anybody wants to make their own notes, by all means do so, and they can be collected at the end and collated and can be part of the CCG's evaluation process. And so please feel free to make those notes. I think without further ado, that's enough in terms of introductions, and I'll pass over to the panel members to introduce themselves, to introduce the presentations before we move into the Q&A session. Thank you.
Good evening, my name's Annette Benny and I'm the Interim Director of Corporate Affairs for New Devon Clinical Commissioning Group.
Hello, I'm Andy Ibbs. I'm Director of Operations and Strategy at Northern Devon Healthcare Trust.
Good evening, I'm Dr. Chris Bowman, retired GP and now Deputy Medical Director at North Devon Healthcare Trust.
Right.
Excuse me, can I just have a point of information? What does ASR stand for, the acronym ASR?
Acute,
I know, but ASR.
Acute Services Review. Okay. So, first of all, I'd like to thank you all for taking the time and effort to come here this evening. Not the best of weather. Hopefully it'll be no worse by the time we finish. I've been, it's not a grey suit, it is a blue suit, but I've been a grey suit in the NHS for 25 years now, and over that 25 years it's remarkable how planning within the NHS has changed. Events such as this would never have happened 25 years ago. I was hesitating before saying the plans would have been developed in smoke-filled rooms. I think NHS smoke, actually they probably were still smoke-filled rooms 25 years ago. And it's so much better that now that we engage the public in our planning and take their views into account before we try and tackle the challenges ahead of us. So what this evening is about is, as you can see, why are we developing a sustainability and transformation plan, apart from having been told to by the Department of Health? Why do we need to review our acute hospital and our specialist services across the county? We want to hear what's important to you. There's a lot that has been said already, but whilst a lot of that is it's said through social media or through the more mainstream media, it's important that we have events like this such that we can hear all the concerns of all the people. And we'll explain how we are going to use that feedback, okay, and hopefully give you assurance that those views, those concerns, etc., will be taken into account. There are a number of these events going on across Devon, and by Devon I mean the old county of Devon, so we're including the Plymouth and Torbay are in that too. And also we'll let you know how you can stay involved. This isn't a one-off. It can be a one-off if you want it to be as individuals, but we'll show you how you can continue to be involved as these plans will develop. So, Devon STP, there are 44, the NHS loves acronyms, doesn't it? STP, Sustainability and Transformation Plan, not the 1970s engine oil. There are 44 STP areas across England. This is only for the English NHS. They are an attempt to bring together all those statutory organisations, particularly with an interest in health. So that's the Clinical Commissioning Group, where Annette is representing today. They're the people who commission, determine what the future needs and how best to meet those needs are. And the providers, whether they be the NHS trusts and also local authority, because of course, as you'll have seen in the media over the last few weeks, social care has a very important role to play in supporting and ensuring the delivery of effective healthcare. And we've got to do it. Whilst the NHS is receiving real terms increases in funding, it's not keeping that increase in funding is not keeping track with the increasing age of the population, the increases in technological advances, and you'll see, we'll put some figures on the financial challenges facing us, but they are huge, and they've been, to be honest, they've been large in Devon for some time. Devon as a wider health economy has been struggling for quite a few years. I first started working in Derriford in '99, and it was tough then. So there's the tough, challenging finances, but also, yes, to an extent, we're doing this. There is a sense of the adversity forcing this, but actually there are some real benefits that we hope. Further integration of health and social care, which I just referred to, but Devon has every right to be proud of the way in which healthcare staff and social care staff work together in the interests of service users or patients. But I think everybody who works in those services know there's an awful lot more that could be done. We may be amongst the best in the country, but that doesn't mean it's good enough. I've talked about the ageing population in the Case for Change, which was published earlier on this year. There are some interesting or scary, depending on how you look at it, charts that show just how much older the Devon population is than the English national average. I can't remember the exact figures, but we're something like 20 years ahead of the rest of the country, and the rest of the country won't have a population as old as Devon's for another 20 years. That leads to increasing demand on services, but also, just frankly, the fact that we can do more leads to increasing demand. And how we best use that technology. Technology doesn't just mean the big fancy scanners in big acute hospitals. It's also what we can do in the patient or service user's home to enable them to stay at home. So we have all come together. I won't bother reading through them all. Just ones that you might wonder what they are. Live Well Southwest is a social enterprise, a community interest company. It's a non-profit-making company that delivers community services and mental health services in the city of Plymouth. I think all the others are probably self-explanatory. If there are any that aren't, please let me know. And whilst those are all of those are sort of at the top table, we are also working with all these other organisations at the bottom. Care UK is a private healthcare provider that operates, delivers some social care, but also some private elective operating. There's 160 GP practices. 160 GP practices in Devon. Devon Doctors, they run the out-of-hours service. So when you phone 111, they run that, but also if they then need to send a GP out to you or ask you to come along to a centre to see a GP in the evenings, nights, or at weekends, then Devon Doctors run that. NHS England, they are the equivalent to the CCG, the Clinical Commissioning Group, but they commission the general practice services. And Healthwatch, your champions, a bit like Which, but for health. They shout for your rights. And Virgin Care, another private operator who run a lot of the children's services for the Devon County Council area. So not Torbay or Plymouth, but Devon County Council. Now, I'm reliably informed the video will start.
There is already much to be proud of about health and social care services in Devon. Staff work hard to provide good care, local people are relatively healthy compared with other parts of the country, and local organisations already work together to meet the needs of local people. However, services are not keeping pace with the changing needs of local people, and it is becoming increasingly difficult to make sure that local people have access to consistently high quality care that is affordable and sustainable. There are a number of reasons for this. People in Devon are living longer, with increasingly more complex care needs that require more support from health and social care services. Some people have more health and social care needs than others. 40% of local people use almost 80% of health and social care. There are 400,000 local people living with one or more long-term conditions, and their needs are complex. Around 150,000 people have a mental illness. Doing nothing is neither affordable nor clinically sustainable. We will be £500 million in the red by 2021 if nothing changes. Although there have been some local successes in changing the way services are delivered, there are many challenges facing health and social care in Devon.
There are health inequalities across Devon. A person living in certain areas of Ilfracombe is expected to die more than 15 years earlier than someone living less than 2 hours drive away in Newton Poppleford and Hertford.
Local hospitals are finding it difficult to deliver services for some of the most seriously ill people, These include stroke, maternity, A&E and children's services.
Less money is spent on health and social care in the most deprived areas. Over 10% less is spent on healthcare for each person in West Devon compared to North and East Devon, even when age and deprivation is taken into account.
There are too many people in hospital beds who don't need to be there. The longer people stay in hospital, the more likely they are to get complications. It is also expensive to keep someone in hospital when they don't need to be there. The main reasons for delay are people waiting for health or social care in the community.
Care needs to be more person-centred and coordinated, especially for people with more than one long-term condition. People do not get enough support to be independent and are going into hospital when this could be prevented. This is particularly important for end-of-life care, where most people would prefer to die at home, but only a quarter are able to do so.
This is also true for children. There are high levels of demand for child and adolescent mental health services, and there are still far too many children in care or in highly, often many miles from home.
Services could be run more efficiently across Devon. Tens of millions of pounds is being spent on areas where staff may be able to provide the same quality of services but more efficiently. Too much money is being spent on temporary or agency staff in hospitals.
Oh, hello. Just to give you a bit of context over a couple of those figures, you'll have seen how many people have a mental health problem in Devon, for example. Well, the overall population of Devon, including Torbay and Plymouth, is about 1.4 million. So 150,000 with mental health problems, that's 10%. Okay, and in terms of the 500 odd million problem by 2021, the NHS's budget in Devon is a little over £1 billion. Okay, so roughly half is the problem. Right. Can we hold that question to later?
Dependent.
There are still far too many children.
Quality of services but more efficiently. Too much money is being spent on temporary or agency staff in hospitals.
Around 95,000 people with a long-term condition also have a mental illness. These people consume a large proportion of the health and social care budget but still achieve poor outcomes. They're also more likely to die earlier in life compared to people without a mental illness.
There are difficulties with recruiting and retaining staff at all levels, making it hard to provide comprehensive and high quality services. Many staff are due to retire in the next 10 years, and local organisations already have high levels of vacancies and staff turnover in many areas.
People in Devon deserve health and social care services that are of the highest quality and are delivered as locally as possible. Local people should be supported to take responsibility for their own health as much as possible. If people do become ill, they should sit at the heart of a proactive, person-centred care system. Achieving this kind of transformation with the funding that is available is not an easy task. But by working together, the NHS and social services with other public, private and voluntary sector providers of care can get the best possible outcomes for local people.
Okay, so that helped set some of the context. Lots of scary stuff in there. But hopefully, if nothing else, it helped to demonstrate why things do need to change. And that's not to say things haven't been changing, things have been evolving for years, but there really does need to be a bit of a step change now, which is why all the organisations have come together and why we're developing the Sustainability and Transformation Plan. So these are our main areas on which we're going to focus. Health and well-being, we need to look much more at what the needs of both the growing population and the growing elderly population are, the rising demands on the care system, and this issue of health inequalities. I think the work for the Case for Change that, as I say, came out earlier this year, that put into stark relief what some people might have suspected was the case, but had never really properly understood, never seen it in bald facts and figures. And quite shocking when we did. We knew about the differences in life expectancy, but the differences in spend, it did seem a little bit odd that those in the most deprived areas with the worst life expectancy had, as a population, had the least spent on them. That was a bit of a shock. And then you've got to make sure that whatever we do is of high quality and safe. The variability of quality, yes, there is variability in quality. Generally, though, the Devon's Health Services are pretty good. They compare favourably with elsewhere in the country, but as long as there's variability in quality, then there's something that needs to change. And mental health needs to be seen just as important as physical health, and I think that isn't a particular issue in Devon. I think it's a national, even an international issue, is that mental health just hasn't had the priority it deserves. Best bed is your own bed. No bed like your own bed. If you are able to be looked after at home, then you should be. You will get better more quickly. And just the simple things like you know where the coffee is. So when you're thirsty, you can get a cup of coffee or whatever. There's a lot of research that shows the longer you stay in a hospital bed, the less likely it is you'll get back up to the state of wellness that you were before you were admitted. And the financial sustainability, 557 million, that's if we do nothing. So half of our budget in 2021 would be gone on paying off the debt before we had anything to pay staff or services. Now, of course, we wouldn't do nothing, but the scale of our ask is bigger than any of us have achieved before. You're generally looking at about 4 or 5% efficiency a year. That's talking about 10% a year for the next 5 years. Okay. So it is going to have a big impact. There will be changes. We just have to make sure those changes are as fair as possible, do not impact on quality, and that we move towards fairer resource allocation, both across the county of Devon, but also across what we in the health service call care groups. So in other words, we need to address the mental health issue. So the STP has these 7 priority areas. And we're concentrating today on that red circled one, the acute hospitals and specialised services, which is what this engagement is about. There will be other engagement events talking about the other 6 areas over time, but there's only so much we can do at once. And so initially we're talking about the acute hospital and specialised services. And I think it's at this area. I'll hand over to you, Chris, isn't it?
Sort out the technology. As Andy said, thank you everyone for coming this evening. Yes, the STP, as Andy was saying, it has 7 priority areas. we've already addressed one key area, or the CCG has addressed one key area through looking at integrated care and through the consultation process, your future care. So this is part 2, and obviously there are all the other parts yet to come. And I think one of the key ones within that is prevention and early intervention, which hopefully will take a lot of strain off the services in years to come and help address the issue around the ageing demographic that we have. But as I say, for tonight we are focusing on acute services. And at this point in the consultation process, we're looking at what are the key criteria we should be using to inform the option appraisal around what is the final configuration of services going forward. So this is around, we're looking at the criteria, and that's what we'll be asking you to comment on. And my last slide will show you what those criteria are. But I'm just mentioning that so you're looking at these next set of slides in preparation for the task tonight. So why are we needing to look at acute services? We do have 4 acute hospitals, as you're all aware: North Devon, Plymouth, Exeter and Torbay, all providing acute services, maternity services and stroke services. However, going forward, or shall we say we have a challenge at this time around staffing, and that is across the whole workforce. We have a 10 to 12% a vacancy gap as far as consultant posts are concerned. Some of those are in key specialities like radiology, interventional radiology. So those people who know where to stick catheters into people when those things need to be done. So thinking of stroke treatment, removal, thrombus and so forth. There's a national shortage of those, and we have a shortage of those in the peninsula, although we do have a service for that. So we do have an issue around staff. And our hospital services, as you can imagine, have had to change over the years. And really, we're needing now to prepare ourselves for the 21st century. When I started, when I did my first house job, then the consultant I worked for had just published a paper recommending that all patients who had had a heart attack were managed at home. I would now be struck off if I was recommending that as a management plan for a patient who had a heart attack. So we've now come on to a highly interventional solution to a problem that 25 years, 30 years ago would have been unheard of. So medicine and what we can offer is evolving, and is evolving quite significantly. But at the same time, the expectations as to what we will deliver and how quickly we'll deliver it have also increased. So as you're well aware, accident and emergency departments have a 4-hour target within which they need to have seen and treated their patients. That is a challenge, as you're well aware, and most hospitals across the country have failed to meet that target, especially over the last winter period. Fortunately, in the southwest, we have done better than many others, but it has still been a challenge. And similarly, with the not enough staff, the government is wanting us to provide 7-day services. We all do provide 7-day services in a lesser or greater extent, but it's wanting us to provide the full range of services over 7 days. With that workforce that we have, difficulties to recruit further, that is going to be a challenge for us all. So with regard to the actual three specialty areas that we're looking at tonight, then each of those work streams are being led by one of the medical directors from each of the acute trusts. So Adrian Harris is medical director at the RD&E, and he and colleagues, clinical colleagues, medical colleagues from the other trusts, together with patient representation, together with many of those other groups that Andy mentioned on that slide, including the ambulance service, are all working together to look at what can be done to improve and make the best use of the resources that we have. But these are the challenges that they're coming across. And I'm not going to go all through because actually there are issues that are repeated through all three and I've already just mentioned. So the 7-day service, staff shortages. As you may have heard on the news some time ago, how many A&E consultants, how many junior doctors are going to Australia because terms and conditions working in A&E units are much better in Australia than they are here. So it's a difficult problem. Inability to flex to meet peaks in attendance. So staff are rotated. We don't necessarily have a sort of buffer, a reserve of doctors ready to come in to actually cope with that. So that can at times of unexpected peak activity catch us on the hop, and that will lead us to failing to meet targets. And it's not the target that's important, it's the fact that we're not treating the patients in a timely way and their care suffers as a consequence. So that, I mean, the value of that target is to remind us that there is a definite patient benefit by actually being treated in a timely way. And as Andy has alluded to, the changing demographic, the increasing ageing population, the issues to do with deprivation, people living longer with multiple long-term conditions, means that when those individuals do attend A&E, it's not a simple quick fix. Their condition has to be reviewed in the context of these multiple problems that they have. So to make that assessment and agree a management plan regarding those patients is much more timely than perhaps it was, as I say, when I worked in an A&E, and both the options around treatment and the assessments you could carry out were far more limited. And once again, inappropriate transfers of care, patients being not seen, not treated in the right place, which in itself can sort of mean that patients do not get the best care that they should. So those are some of the issues from the urgent and emergency care. With regard to stroke, that work is being led by our local medical director, my boss, George Thompson. And as you will see, the issues are similar, not enough consultants and staff, an increasing number of older stroke patients. Different hospitals have different approaches, leading to variation. And once again, variation can be a good thing, but it should be to us, the way we deliver it, the outcome should be the same. Now, if that variation is meaning that the outcomes are different, then there's an inconsistency that needs to be addressed so that the level of outcome, the improvement that we provide, is consistently high across the patch. And probably more particular to stroke services, it's the public awareness of what to look out. What are the signs to look out for in a stroke? What is going to prompt somebody to seek help quickly? Because the clot-busting drugs that really can make a difference, and that hopefully will be able to be delivered at all hospitals, are drugs that have to be administered within 4 to 5 hours. So if it takes somebody an hour or so to recognise that they've got a stroke, or what might be a stroke, then they call the ambulance, then the ambulance got to get them from where they are to the hospital. You could already be 3 hours into that process before you even get treatment. So the more we can shorten any of those time bands, then the quicker we can get people to really effective treatment.
And so am I.
Yeah. And we're looking at the possibility of placing
So this is not, can we say, there are no options on the table at the moment as to what, there are no options on the table, no decisions have been made.
Excuse me, if you let Chris finish, we've got time for questions and answers later, so please let the presentation carry on.
Yeah. So, there obviously, as I say, in that sense, we need to ensure the public is made better aware of the signs and symptoms to look out for regarding strokes. And as I say, and your point is access to the right speciality and treatments at the right time quickly improves outcomes. And we're all signed up to that. And as I say, as medical, this is being led by medical directors. Medical directors, their responsibility, accountability is to ensure the safety of the services that they provide. Therefore, we are not.
But you've got yourself in
please let Chris finish the presentation before you make comment. Thank you.
Okay. So, well, perhaps let's address that perhaps in the question time. But shall we say we're looking for solutions to a problem, and we have a significant problem that needs to be addressed regarding the finances. But that solution has got to be one that is safe for patient care. And then the third is Maternity, Pediatrics and Neonatal Services. And this is Rob Dyer, who's the Medical Director at Torbay. And once again, staff shortages across all services. High use of agency staff. The problem with agency staff, A, it's expensive, and B, and certainly work we've done in North Devon, we can show we've dramatically reduced the amount of agency staff we use. And correlated with that has been a reduction in the harm events for patients, which is not surprising. If your own staff are providing the care, they can provide a continuity of care, they have a better understanding of the patients, rather than somebody who's coming in, doing a session and going away. So there is a problem with using a high use of agency staff. So all of us and the government has sort of set targets that we must achieve to reduce that. But there are obviously benefits to patients by reducing agency staff. And once again, because of staff shortages and so forth, to provide that resilient 24/7 service becomes an increasing issue. Similarly, we have a reduction in trainees, means further staff shortages. That's not just around this speciality, that's across the board. We in North Devon, we are very short of trainees this year, and we depended upon our trainees to support all our services. So that is putting an extra pressure on the teams that are there providing the current care to yourselves. And for women, there are limitations in the range of services that we can offer, partly as a consequence of the fact we haven't got the workforce available to actually support all these things. So the choices around where and how you deliver are reduced as a consequence. And similarly, we have more patients with complex needs. So even managing patients through their pregnancies is more difficult than it used to be back when I was a junior doctor. So, to reiterate, why are we engaging with you? So we haven't made any decisions, and I think that has to be clearly understood. This is partway through a process of making a decision further down the line. But we need to decide what criteria we're going to use to determine what is the best decision. And the next slide will show what our clinicians have come up with. But tonight is about getting your views, whether you agree with those criteria or whether there's other criteria that you feel are as important or more important than the ones that have already been identified. And as I said, that really will feed into how we take this process forward. So, not surprisingly, top of the list, safety. And as I say, all of us, none of us come into this job to cause harm. So we are all looking to ensure that we're providing a safe service. Similarly, the quality and outcomes. We're looking to acknowledging that we have not only a difficult financial situation, but challenges with workforce. We want to maintain the quality of our services, or if we can, use this as an opportunity to actually think about different ways of working as networks, shifting people from one site to another to actually improve the care that we can provide to a greater number of patients. And that brings on to access. Maximise the ability of patients and carers to access the service. So that is about how local can we keep services, how distant do we have to have those very specialist services so that we have that critical mass and the appropriate number of patients so that those specialists are able to maintain the skills to ensure that they have good outcomes from the interventions that they perform. So not only is that the access around those services, but it is that we also manage to provide, not necessarily, this is not so specific around the acute, but those services within a timely way, so people aren't waiting weeks, months, years for the hip replacements and whatever else they need. Yes, you do. It's in your pack. It's there. It's in. No, I don't think it's in that one. It's the one with the picture. The picture.
I think it's in the large sort of double-sized pack,
Yeah,
and a copy of each slide in that pack.
Okay. Yeah. So, service sustainability. Once again, as I say about the workforce, there are deficiencies with it or vacancies within our consultant workforce, our nursing workforce, our therapy workforce. Social services also obviously have their vacancies as well. So we got to develop an environment that actually attracts people to want to come and work in this part of the world. And that needs to be supported by appropriate training and so forth. And we've got, as we are all taxpayers, we do need to ensure that we are providing the best value for money in what we are providing. But at the same time, where it's possible, we wish to promote patient choice so that there is more choice around the services you can access and where you can access those services. And I think also very significantly, I know it's at the bottom, is user experience. And I think that is very important, and I think we have a lot to learn about how we can make our services more accessible to you by listening to what you feel is important as to how you can access those services. I think we set services up that are probably convenient for us, but not necessarily so convenient for yourselves. There obviously needs to be a compromise in the sense that we can't local village reviews that we used to do in the practice wanted a GP to be in every village. And that's understandable. Why wouldn't you want that? Of course you would. But when you're a rural practice, 5 GPs, 15 villages, it doesn't work. So there has to be some common sense played in and a compromise as to what is achievable. But wherever possible, one would wish to ensure that the outcome of this is to improve the user experience. And I think that is all that I need to say as part of the presentation.
I think that takes us very, very nicely and smoothly into the next session, which is we've got 30 minutes for question and answers. I would like to thank the panel for giving their presentations. Although I've seen the film before, I certainly think it's been open and transparent. The 30 minutes we've got is an opportunity to ask questions and to raise queries and to make any points. I would ask for those points and queries and questions to be put over in a constructive way, because I realise these issues are the source of much passion and concern. But I think without further ado, I'll open it up and ask for hands. There's one here, and then I'll move to the back.
Thank you very much. My name is David Brenton. I'm a councillor on Torrington District Council and also Bideford Town Council. There's a big question mark over the credibility of these exercises, and I'll tell you for why. Although we're not discussing community hospitals tonight, it will lead into my main question, and that is, on Friday, Holsworthy Community Hospital was closed suddenly, and we were told at a council meeting on this Monday from the ward member for Holsworthy that apparently the MP was aware of this going to happen about 2 weeks prior to the actual closure. So it didn't give, he never told the local community, so it didn't give them the opportunity to try to recruit what they needed to keep it open, namely one nurse. Now, the thing is, you mentioned in your presentation about the recruitment of staff. If you have a hospital which has got a big question mark over it, how on earth are you going to encourage, especially consultants, to move from where they are at the present time, to move into North Devon when they think, well, maybe I won't have a job there in about a year's time? We do need to overcome this this question mark, because although you say no decisions have been made, what we'd like some reassurances that some of the key services will be kept open come what may, especially as the business of transport to Exeter or Plymouth has been well exercised in the local press and by local people, and that is a big, big concern.
Thank you. Would the panel like to respond to those points?
There are quite a number. There were quite a number there, weren't there? First, it must be clear that Holsworthy is not part of this process. Today is about identifying the criteria against which we will be making the decisions in terms of for the sustainability and transformation plan. But what I would like to reassure you on is that there will be engagement events around Holsworthy. We will be doing those very shortly. There is a difference between when you see a juggernaut coming over the horizon and you've got time to prepare and change, to be able to spend a good 6-12 months planning like we are doing now and engaging with the public properly as we are now, to when something is urgent and necessary and you have to move quickly. So as happened last week, some of the facts you stated I would take issue with, but as I say, it's not really for now. We've got half an hour for questions and answers on the criteria for the STP, but I'm happy to discuss them with you at another time.
Okay, thanks. There's a range of hands, so I'd move on to the next question. And there was one hand up over here that I think it was yours.
Yes, it was. Okay. Well, it was along similar lines about the cottage hospitals. You talk about that you need to care for people closer to home. So why have so many cottage hospitals across Devon been closed? That doesn't make sense.
So that we can care for more people at home, which simply what we've been able to show with the closure of the hospitals that we've undertaken, that as a consequence of that there have been reduced admissions into the acute hospital from those areas. So those patients who would have otherwise gone into the acute, there is no longer in a community hospital, so they are being managed in their own homes.
Hospital, there's nowhere for them to go. If you kept the cottage hospitals open, they'd be able to be cared for closer to home. So why are they closing?
As Andy said earlier, the longer you have somebody in hospital, the more likely they are will not be able to regain the level of independence that they had before their admission. The average length of stay in the acute hospital, since we have closed the community hospitals, the ones that we have, the beds in the community hospitals, that is, the length of stay in the acute has risen from something like, average length of stay has risen from about 4.5 to about 5 days. What we have managed to get rid of is the 23-day length of stay that was additional to the 4-day length of stay that some patients had because they went into a community hospital. That had a significant impact on their independence, both by virtue of the fact that they were in beds, their muscles would waste, and therefore they were more vulnerable to falls, pressure damage, and so forth. So hospital beds are not the answer to safe care. And we are all trying to maintain individuals' independence, because independence means that there is less burden on the health budget and less burden on the social care budget. And as we're all saying, we're wanting to reduce the demands on those.
For that, there's quite a number of hands going up. The gentleman over here, I think, was next, and I'll do my best to get back to others. Excuse me, can we take one question at a time? The gentleman here is next. I'll try and get over to you in a second.
Yeah, my question centres mainly around communication, transparency, a couple of things like that. I mean, you mentioned in the presentation around the fact that there's a lot of kind of thought already in the room. There's kind of a sense of adversity was the quote that you used as well around everybody here. I don't think believes that much of what is going on is actually to their benefit for certain, that's for sure. And I think there's also been, you mentioned a lot about the social and mainstream media about kind of whispers about what is happening and what isn't clear. Even this session tonight, I think from the kind of attendance here, not many people knew that this was necessarily happening. Not many people were aware of what's going on. I think there's been a sincere lack of kind of clarity from the NHS point of view as to what the plan is. A lot of people believe that North Devon Hospital is closing. And I know that you can stand up there and say it's not, but you're not going to change that by talking to 15 people in this room compared to that being on social media all the time. The other kind of thing was in the presentation, I think that a lot of the stats really did lack a lot of context. Which I'll follow up on afterwards. But I mean, you were talking about kind of the deficit, but that wasn't in comparison to any other trusts. I think there's a kind of genuine feel that people are being hard done by, especially in North Devon, and I don't know that the NHS are really doing anything to really combat that. So I guess it's not really a question so much as, do you feel there's more that you could do to make people feel at ease that this is only part of a consultation or a plan, as opposed to it's a done deal where people genuinely feel that the decision's already been made?
Okay, there's always more that we can do, and as I said when I was talking, this may not feel much, but this to me this is so much more than I remember in the past. But there is always so much more we could do. I'd have to say that there are lessons that we can learn from this to scotch rumours. You know, I don't know what decisions are going to be made as a result of this, and nobody does, because until we've identified the criteria which you're helping us form, you can't make a decision, and so that's why I say it's scotch rumours, which whenever there is a review of health services anywhere, people will always look to their local service and see and be concerned that it is under threat. That is a natural reaction. But apart from being completely honest and saying there ain't no decisions made, that I'm not sure in that respect what else we can do. But you asked the question about the context of the figures. You'll know that I said that the NHS more widely, generally, is facing huge financial pressures. The precursor to the STP in Devon was, or at least in North, East and West Devon, was something called the success regime. And the success regime was launched, it was announced nigh on 2 years ago. And there were 3 areas in the country that the Department of Health said you need a success regime. Devon, Cumbria, I think, and I think Essex was the other one. And that was because those 3 health systems had the worst financial problems, the worst financial outlook in the whole country. Now, in the and once we'd done the work for the Case for Change, we realised just how big a problem it was. You saw the figure of 527 million, about 50% of our allocation. The going figure for the rest of the NHS is between 35 and 40%. So still blooming big, but we're right there at the top in terms of the ask required. Some people will say, well, Devon isn't getting enough money from the government. People always argue about the allocations from the government. People will always say, we've got more narrow roads, therefore our district nurses will take longer to get to houses, therefore we need more money. Other people will say, we've got very high proportions of deprived people in the inner cities, therefore we need more money. Others will say, we've got a very ethnically diverse population, therefore we need more money. There will always be arguments about how much money you should get. What we do know is that any one area of the country saying we need more isn't really going to be listened to. We have to deal with what the money we have. However, when it comes to equity, we do have a responsibility to ensure equity of the money we get, that we spend it fairly across the county and across the care groups. I think that was it.
Okay, thanks. Just like to thank you for that question. I think there's a learning point in there for myself and Healthwatch as well, so thanks. I'm going to take the lady here and then I'm going to come down the sides.
Thank you. Well, there are lots of things I want to say, but I'll stick to three. Firstly, what surprised me is that when you've listed all the problems that we have to face, the challenges, you've left out the main ones. One is the internal market, which has cost the NHS so much more. If you're having to pay private institutions, for example, the independent sector treatment centres and the alternative provider medical services, they all cost a lot more than when you had a proper National Health Service. And then there's PFI, which with the cost of PFI, we could have 40,000 consultants, all our nurses, 40,000 GPs, and still for 10 years, and still have £67 billion left over. So all these things are costing money, and they're far more important than the fact that we have an ageing population and complex needs. There's been serious underfunding, we know that over the years as well. But before people started tankering with our NHS, it was the most efficient, the cheapest in the world. And it's the introduction of private companies that has caused an awful lot of the problems we have. Secondly, I want to talk about care in the home. Yes, it's great to be in your own bed, I agree. I'm sure that is the best place, and I agree with how if you stay in hospital, you can get immobility problems and infections. But there aren't that many people who are going to have somebody at home who can look after them, and we all know that social care is not adequate. Torrington is being used for the rest of Devon as an example of a success, and it's a failure. There's a legal case now before the Secretary of State because of what's happened in Torrington. People have died as a result of the community hospital being closed and inadequate social care being provided. Other people have been left at home in a terrible state. So we're being told all the time that these things are fine. The third thing I want to say is about rumours. Well, I read the published SDP, and it is very, very seriously hinted that North Devon is going to lose its acute services, its maternity, pediatrics, neonatology. The hint is very, very strong. If you read it, the leaked SDP, which is the one we didn't want to read, says that each footprint, and Devon is one footprint, is going to have 2 emergency and acute, urgent and emergency departments. And it says that Plymouth will be the lead one, and it is very likely that Exeter will be the second one rather than North Devon. So you tell us we're spreading rumours. These have come from what we've read in your documents.
Okay.
Thank you. I think 3 for the price of 1 there, but panel, would you like to address those?
Okay. In relation to the first point, you make a number of points that are things completely out with my control, or out with anybody's control in Devon. They are the introduction of PFI, the introduction of private sector competition. They were introduced in the late 90s by the then Labour government. The introduction of the purchaser-provider split was introduced by the Tories in the early 90s. So, you know, we have to, I go back to the response I gave earlier, we have to deal with what the cards we've been dealt. And some might say that the fact that there is, I believe, only one PFI hospital in Devon, and that is a small community hospital, is probably one of the things about which we might be relieved, because they are expensive. They are expensive. But in relation to the purchaser-provider split, actually, look at the STP. That is getting rid of the purchaser-provider split. The means of financing the local NHS this year has in many ways moved to move away from the amount of time and effort spent on contractual discussions in arguing, debating about exactly how many patients are going to be treated where, and getting payments for each individual patient. But that has freed up resource. So, you know, that is something which I think from my perspective, is one of the best things so far that has happened through this whole STP process. It has established new working relationships across all the organisations delivering health and social care in Devon. And I mentioned earlier that we've had a financial problem for as long as I've worked in Devon, and for most of that time I thought, I don't know how we're going to get rid of, how we're going to get out of this. Now I'm actually got optimistic about it because everybody's working together. And we are holding events like this to help you inform us. The second point in relation to the care and the home... Sorry,
If we're getting rid of the purchaser provider, does that mean we're not going to get rid of private consultants? We're going to get rid of that now and just have a proper NHS?
Again, that will depend on a change of government. Because actually some of the requirements in terms of contracting are enshrined in Acts of Parliament. But I'm sure you will find that actually I think we're using the private sector less than we have done previously. The NHS hospitals are trying to consume as much of their own smoke as possible. That may be not the best phrase to use, but we're trying to cope as much as we can with the demand that comes upon us. I'll ask Chris to respond to your second point about care in the home, if that's okay.
And before I do that, I'm struck by the sort of rosy view that people have of the NHS prior to this last decade. And I think one has to remember, as I was said in my talk, that when I was a junior doctor, then if you had a heart attack, the best form of treatment that was being advised by my specialist consultant in cardiology was that you could be managed at home. That would now be unacceptable treatment. Since I qualified, the amount of regulation, standard setting, and everything else that has come into play has improved standards across the NHS. You only have to look at the cancer 2-week wait to see how that has improved outcomes for patients. So the view that everything was rosy in the garden of the NHS back in the 50s, 60s, and so forth, I totally disagree with. I'm not saying that everyone did a good job. I think, as always, those who go into the caring professions have been dedicated individuals, but actually we have many more tools, we are more skilled and so forth to deliver much better care for individuals than we were back then. Which leads me on to why we can provide better care in the home than we probably did back then, because we do have better skilled and trained staff who have worked in hospitals and who have also been trained to work in the community. And as long, as I say, we can provide that care in the community, then I think the outcomes of patients are improved. I'm not aware of anyone who has died as a consequence of closing the community hospital beds in Torrington. No, there are not.
Let Chris finish, please.
Can I say, if we had all the staff we need, then my priority would be to actually reinforce the community services, because that is the best place for patients to be and individuals to be cared for. I'm still not aware of any deaths associated with the closure of beds in Torrington. I've not heard of these that are specifically said to be as a result of. We have no evidence of this. And it is not part of the dossier that Stitch has produced. That is completely different. And there, from my perspective, and I've checked this, we have no letters of complaint about the services provided to individuals in the Torrington area since we closed the community beds.
Okay, thanks.
Sorry, I'm well aware of the Tucker report. Thank you.
A point well made. I think for time-wise, I'm going to have to move on to the next question. We've got the lady here who had a hand up a little while ago. So just a question for yourself for a point, please.
Sorry? Oh, thank you. Thank you. Firstly, I'd like to dispute Dr. Bowman's comment that people go were discharged from hospital to the cottage hospitals, and then they just had to stay there. Most people that were discharged that I know of and that I visited were actually receiving physiotherapy and help to enable them to get back into their own homes. Would you like to come back?
Certainly, and I'm not disputing that. You're absolutely right. And so now they get that reablement care back in their own home. Or they might have a slightly longer stay in the acute so that they are in a position where they can receive that care in their own home.
If it works and if you have the staff, which you may not have.
Interestingly enough, since we've closed our community hospitals, then as far as the acute hospital is concerned, we are performing much better than our local trusts are concerned. As far as managing discharge of patients, we have very few unfilled packages of care. The whole system, and it's not... have to remember that you cannot look at one component in isolation. It is about how we manage patients through their pathway of care, from the time they are admitted, through their admission, and out back into their own home. And we've been able to make significant improvements into that whole pathway and ensure that they get intensive therapy as best we can in the hospital, so that they actually, their recovery is much quicker than it used to be.
If that works, then I'm very, very pleased. But I would like to also say that I understand that you're here to get our views on healthcare in North Devon. Well, I've stood on the streets of Barnstable, Bideford, Westwood Ho and Northam and asked every passer-by that I could for their views. And not one, I repeat, not one has been anything other than appalled that any cuts to North Devon District Hospital are even being discussed. My view, and everyone that I know and have spoken to, is this: we demand, not ask, but demand that there are no cuts to NDDH. We're disgusted that you've seen fit to even be considering them, or close our local community hospitals and care homes. I won't dignify this sham, supposedly consultation, with pleading about distances to Exeter or Derriford when you have a stroke, heart attack, go into premature labour, or need a routine appointment, etc. Because only a fool would not know the necessity of maintaining all our services at North Devon District Hospital. And to sum up, if you are the body of people that sanction closing our local hospitals and care homes, then quite frankly, you're not fit for purpose. We heard all the tragic, horrible news of the death of Callum, an 8-year-old boy who died yesterday. His local hospital, the Alexandra, was only 2 minutes away, but he was made to travel 21 miles. The Alexandra Hospital fought hard against STP proposals and lost. I believe that death sits on STP's shoulders. These are my views, and my questions are, how much more of our taxes are you going to waste on these committees and bogus consultations? How many more people will have to die? And have you already made a decision? And are you just testing whether or not enough of us will fight? Well, understand this, we will. You want our views? Anyone who supports cuts to North Devon District Hospital, well, stand up. And if you cut our services, I believe the STP stands for Stuff the Patients.
Thank you. I think that was a point, not a question. I don't know whether the panel want to respond to that, having heard what was said.
A couple of points, if I may. With 500 million to find, there have to be savings. Now, whether savings equals cuts it will depend on what the proposals eventually look like. But savings have to be made. I made the point earlier that because North Devon is small and because it is natural for people to be protective and to be concerned about the services in North Devon. There was a point made earlier about what was said in the case for change. It was actually, I'm afraid, weren't actually quite correct in how you quoted it. But it is a matter of fact that we've got an august Royal College that makes certain recommendations in terms of staffing for things like maternity services, etc., that we in North Devon simply cannot either afford or justify. So the Royal College of Obs and Gynae would say that you have to have, is it 24/7 consultant obstetrician cover? That would require us doubling the number of consultants. Where would we get the money from? But also, actually, with only 1,500 births a year, each individual consultant would have relatively few births to look after, and would they therefore be de-skilled? We think there's a good, safe model in North Devon, but the fact that we don't meet national standards from royal colleges means that the question has to be asked. It has to be looked at. It doesn't mean because we're looking at it, we're going to lose it. It means we have to look at it and demonstrate that it can be delivered safely. Yes. Well,
we all know people. I have a friend who had a baby that was born 2 pounds because she was premature. She's alive and well today because of North Devon District Hospital. She would not have been had my friend had to go to Exeter because they live in Brendan. And it's double the journey.
I'd simply reiterate my point is that where, and it's not just North Devon, there are services elsewhere that are not meeting recognised national standards. If they're not, we are duty bound, are we not, to look at them and to say, actually, is there a better way of doing this? Well, no, the first question is, can we demonstrate that these are safe and high quality? If not, is there a better way of delivering it? I think that probably answers the more general point, doesn't it?
Thanks for thank. I'm going to have to close this question and move on to give other people a chance to have their views. I'm going to take one more question from the lady over here who had a hand up ages ago. Then I'm going to suggest that we move into the desktop discussions. And during the desktop discussions, there will be time to make and note the points that will be fed back. But one last question from this lady here at this stage. We've already overrun. No, we have an agenda. The CCG wants the desktop discussions and to feed back the information that enables the CCG to move on to the next stage. So no, I don't suggest that we do that. I'll take one last question and then we'll move on to the desktop discussions.
No point in carrying on with asking us to list criteria or any other proposal if we have not satisfied ourselves that we understand what we proposals are about.
I think the CCG would like to know.
I have to say that the NHS has recently been criticised with reticence about engaging in public information by a recent National Audit Office report, and I've heard quite a lot about it. I spent several weeks trying to get information to find out how the clinical review process works, and I've come along today to hopefully find that my fears were not actual, and I find that they are. So I feel that we are being silenced here. We're not being given a chance.
Why don't we have a vote? Democratic vote.
We have an agenda. The CCG is arranged. You can make the points that you would like to make during the desktop discussions. Well, if you don't want to continue with the meeting, you may well wish to leave, but the meeting is going to be conducted according to the agenda. No, I'm not on the defensive. I'm trying to get the balance between hearing the public views and supporting the CCG in getting the information that helps them move to the next stage. So I'm going to take the last question at this session and then we'll move on.
Where do I press there? All right. I took part in the consultation about community hospitals, just a comment, and Holsworthy and South Molton were the 2 hospitals that were kept open, and I could see the point of all that. But I think it does lessen people's confidence in consultation when something like happens as has recently happened with Holsworthy. because I feel that my comments and the consultation isn't worth what I thought it was. Anyway, the point I wanted to make is I live in Heartland, so I'm 65 miles from Exeter, and I agree community services, lots can be done close at home and in home. I was a nurse, I also worked in the community. I know people get infections and problems in hospital, but some care is needed in hospital. And so what do you consider when you talk about specialist services which need to be provided in those specialist areas? What do you consider? I would think of heart surgery and neurology, for example, and would be willing to travel to Exeter or Plymouth for those. I would feel that things like maternity, A&E, pediatrics and stroke care were a much more basic level of care that did need to be provided at a reasonable distance for patients and carers who need to be closely involved to be able to be active in that care and help lessen the time that people spend in hospital. And 65 miles on, small roads, to me, makes that impractical. So what specialist, when you talk about that, and what is what we would think of as basic care, really?
I think you make a really, really good point. I think that is the challenge and also the opportunity of this whole process, is to determine what can be delivered locally, what is appropriate to deliver locally, and what is safe to deliver locally. So that, when I say locally, that would be within the community of Holsworthy or Heartland for yourself. Then what can be delivered through a DGH, and then what needs to be delivered in a tertiary centre. And I think the opportunity of this, of an STP, is that it is bringing all providers together to work for a solution that works for the whole county. And I made that point about the interventional radiology. Now, there is no prospect, I would suggest, that will ever come to North Devon. As I say, it is a very specialist intervention. It has to be associated with a neurosurgery unit. We only have one of those. But how do we ensure that as many people as possible from North Devon benefit from that? Because we can't move the service here. So are there other ways that we can improve flow of patients, improve communication, can improve transport and access, so that is a viable option? I don't know, but we've never really had a look at that before, but this process actually provides an opportunity. The whole thing about clotbusters, I think that will probably require that sort of service to be delivered more locally and not necessarily at centres. And we can't, but I don't know the outcome. I really don't know the outcomes, but you can, we all got to have common sense about what the art of the possible, as opposed to what we might all wish for. But I think that might be what comes out. But there is still need to go through a process of determining what is appropriate to deliver at what level, and how do times and access to those things, what impact does it have on patient outcomes? I think that's a very appropriate and sensible piece of work to be doing, and that is what is happening in each of those work streams. So that's why none of us do know the outcome of this, but there might be some exciting new ways of delivering services. You might have a flying obstetric team that is able to deliver. I don't know, but it provides a mechanism whereby all providers and commissioners can get together and just shake the whole system up and just see, what can we do? What can we do to make it better? Thank you. I would certainly, as I say, there are financial restraints, there are human resource restraints. Those are givens, and we can't change those. We'd like to improve recruitment. If we can, we will. If we haven't, I use the word exciting solution to this problem, that people think, wow, this is the place to come and work because they've been so innovative, and that this looks like a real good place to work, then sure, that in itself may address many of the staffing solutions. But I think it is about all the providers working together, recognising the strengths and weaknesses of the various services, and finding a way that you can best manage the patient's care to achieve those best outcomes. But yet there is a need for realism in what can be achieved. As I say, we are starting from a high threshold, and that the outcomes for patients in this part of the world are generally very high anyway. But yeah, I certainly don't want to see those standards, those outcomes deteriorate. Why would I? I mean, I've not worked in the NHS for 30 odd years and be out here speaking in the public to say, I'm looking forward to this because it's going to mean the standards of care we provide are going to be worse than they used to be. Why would I want to do that? So I'm supporting this because there's a reality about it needing to be done, but I want to ensure that we get the best outcomes for patients through this process that are achievable.
So that question, and for the panel's responses to all of those questions, and thank to everybody who put a question over. And I'll remind everybody that if you've not had the opportunity to ask a question, do write it down and it will be presented to the CCG. I'm conscious that we've spent many more minutes on the question and answers than was intended in the agenda, but I would like to move on to the tabletop discussions. There's 2 questions. I think they're part of the plan and they are now up on the screen over there. So if we could give some thought to those. We've got about half an hour left, probably just a minute or 2 over, rather than the full hour that was originally envisaged. And certainly I'll come round and try to sit on each table, and I think probably the panel will as well, so it's an additional opportunity. So let's move on to the next session, and thank you for the question and answers. Okay, I'm now going to draw the session to a close. Don't think I'm making much headway here, actually, but a few learning points for me this evening. Can I draw the session to a close by thanking particularly the participants that have come out on a wet and rainy night and made many, I think, constructive and very passionate points of view, and are still making them in some areas. It is appreciated. Can I also remind everybody that the views that have been made are to be collated, will be presented to the CCG, and one of the duties and responsibilities of Healthwatch is to make sure that that's the case. Can I also remind everybody that if there are any major proposals that are going to come around as the result of the discussions, there will be further rounds of consultation with regard to any major changes. So that's the good news. There will be further discussions. The bad news is you might not have seen the last of us, I guess. But I'd also like to thank the panel for coming out tonight, and thank the CCG team, Sam and Sally, for organising it in such an effective way for us. So can I now draw the session to a close? And I think somebody's got a hand up, and I'll take one final point. If it's
So I'm actually not the CCG, I'm the local trust, but the CCG and we all together as part of the STP have organised these 12 events across Devon, so 3 of them are in North Devon, but in addition to that, there are a number of events that is happening with town councils. So we've been going to town and district council meetings, which are being held, the majority of them in public. So there was 3 on Monday that we're going to, that people can also attend and have their voice heard during that process. But there aren't any plans to hold any more of these type of events at this time. Yeah, there's one in Barnstable on the 17th. Okay, so it's just about making it more visible and making the Barnstable one more visible. Yeah. So, yeah, absolutely. So we'll feed that back to the CCG, yeah. Also on our trust website, the events are on our Northern Devon Healthcare Trust website. We've done quite a lot of stuff on social media about it, and we've also spoken to the Journal, who are publicising it as well for us. So yeah, and hopefully more people will come to the one on the 17th. Not in North Devon, no. Yeah, okay.
Okay, could I just remind everybody the point I made earlier, and the point Annette has just reminded me, this is the beginning of the process. If there are to be major changes, then there will most certainly be further sessions. So there is likely to be further opportunity. But I think some of the points that have been made have been real learning points, both for Healthwatch and I think for the process. And we'll make sure that those points are fed back with the intention of trying to make any further arrangements more effective and more meaningful for everybody who's here.
So there is an STP website, so it's devonstp.org, I think, .org.uk. So there, it's on the presentation. So there is a Devon STP. If you search Devon STP, it'll come up, and on that there is a engagement and get involved section, and on that there's an online form. So this feedback form that's here is available online, and people can, get all their friends and family to fill it in. So that would be great. Thanks.
Can I once again thank everybody for coming, and wish you all a happy journey home, and thank you for your participation.